Hello all, welcome to another session of vertical integration program designed for UG students. So today we have a very clinically and academically relevant topic, that is pneumonia. To have this discussion, we have a eminent panel of resource persons. To introduce Dr. Girish Kumar sir, who is the principal of Amrita School of Medicine, Dr. Shilpa Radhakrishnan, assistant professor from the Department of Radiology, Dr. Divya, assistant professor from the Department of Microbiology, and Dr. Nandita SR from the Department of Anatomy. So we will be following the usual pattern of questions to each of the panelists. To start with, to Dr. Nandita. Nandita, can you give us an overview of the general anatomy of lungs?
Yes, sir. So the lungs are situated in the thoracic cavity on either side of the mediastinum. It is conical in shape. It has an apex. That apex extends into the root of the neck. It has a base that rests on the diaphragm. And then the right lung, it has 3 lobes separated by 2 fissures, and the left lung has only 2 lobes. Right. And the lungs has 2 surfaces. One, a costal surface that comes in contact with the 6, 8 and 10 reps along the mid-clavicular, mid-axillary and scapular line respectively. Right. And then it has a medial surface. The medial surface has 2 parts, a mediastinal surface and a vertebral part. So vertebral part comes in contact with the thoracic vertebra. The mediastinal surface represents, or it has the hilum of the lung, which is the most important structure that helps in distinguishing the right from the left lung because of the arrangement of structures inside the hilum. Right. So in the right hilum, the structures from above downwards are eparterial bronchus, the right pulmonary artery, hyparterial bronchus and the inferior pulmonary vein. And on the left side, it would be the left pulmonary artery, the left principal bronchus and the inferior pulmonary vein. Right. The mediastinal surface of the lung has so many impressions that are produced by the viscera. In the right lung, major impressions are produced by veins. So the arch of Assagus vein, the superior vena cava, inferior vena cava, and the impression of the right atrium, because these veins are opening into the right atrium. So basically on the right side we have blue color more, and on the left side we have impressions by the artery, the arch of aorta and the branches, the left common carotid, the left subclavian, the descending thoracic aorta and the left ventricle from there take origin from. Okay. So these are the major impressions. All right. And arterial supply is, this lungs is mainly supplied up to the conducting part, that is from the bronchus to the terminal bronchiole will be supplied by the bronchial artery, while the respiratory part, that is the respiratory bronchiole and the alveoli, will get its nutrition from the pulmonary plexus. So the vein is bronchial vein and the other vein would be the pulmonary vein. Bronchial veins is draining into the Assagus system of vein, but the pulmonary veins is opening into the left atrium. Okay. So, and one more thing to add, the bronchopulmonary segment. Okay. So, the bronchus, it undergoes division. So, that whole division is called as a tracheobronchial tree, and that is followed by the pulmonary artery and its branches. Okay. So, a segment of the lung, when it is aerated by a tertiary bronchus, which is the third division, is called as a bronchopulmonary segment. So, there is 10 bronchopulmonary segment in the right lung and 8 to 9 in the left lung. Okay.
Okay. So now we have got a good idea about the basic anatomy. To Dr. Divya, can you just enumerate the various causative organisms for pneumonia and also the broad classification based on it?
So, as we all know, pneumonia is the inflammation of the lung. So, from the epidemiological point of view, we can classify pneumonia into community-acquired pneumonia and hospital-associated pneumonia. So, first coming to the hospital-associated pneumonia, it can be broadly classified into 2. Patient admitted to the hospital and they have passed 48 to 72 hours and they are developing new symptoms. We can consider it as hospital-acquired, and some patients are on ventilator. So, mechanical ventilated patients after 48 to 72 hours and new onset of symptoms, we classify them as ventilator-associated pneumonia. Okay. So this ventilator-associated pneumonia has again classified into early onset and late onset. Early onset within 4 days and late onset more than 4 days, 5 days onwards. So, in case of early onset ventilator-associated pneumonia, normally the community-acquired pathogens will be the causative agents like MSSA, strep pneumo, all those can be. But in case of late onset pathogens, mostly MDR pathogen. But basically, when we talk about a hospital-acquired pneumonia, mostly MDR pathogens like Pseudomonas, Acinetobacter, MDR E. coli, Klebsiella, and MRSA are the main causative. Then coming to the community-acquired pneumonia, the community-acquired pneumonia can be classified based on into bacterial, viral and fungal. And also they can be classified into, based on the area it is affected, into lobar, that is lobar pneumonia, as well as interstitial pneumonia. Also we can say it as typical pneumonia and atypical pneumonia. So when you talk about the lobar pneumonia, the most common agent is Streptococcus pneumoniae, followed by Haemophilus influenzae, and when it is atypical pneumonia, it is Mycoplasma, Chlamydia, and Legionella pneumonia also can be the causative agent. So coming to viral, the most common is influenza, followed by COVID. Adenovirus and respiratory syncytial viruses are also causative agents. And respiratory syncytial virus is more common in children. Fungal is most commonly seen in immunocompromised patients. Pneumocystis jirovecii is one of the causative agent, or as well as Aspergillus can also be. Very rarely we can get parasitic infections with Paragonimus westermani and also Ascaris lumbricoides causing Loeffler's pneumonia. In addition to this, there are other various rare pathogens like Burkholderia pseudomali, which is causing melioidosis, Coxiella burnetii causing Q fever, even plague, pneumonic plague is caused by Yersinia pestis. Some, if you have contact with birds, Chlamydia psittaceae, psittacosis can be there. All these can be causative agent of pneumonia. It's a broad classification.
Thank you. To Girish sir. So from an undergraduate point of view, like what are the important points in history taking, and what are things one should be looking for in clinical examination in a patient with suspected pneumonia?
Like Madam told, you can know any pneumonia, any respiratory infection coming to emergency room or your OPD. You can broadly classify them into viral and bacterial. These are the two important things. So what in viral infections, we all know that any viral infection, respiratory virus can produce rhinorrhea, sore throat. All these URTA symptoms will predominate in the first phase of the infection. But after some time, suddenly patient develops respiratory infection. That means LRTA will increase, that features of LRTA will increase, and they develop florid pneumonia. Whatever it is, in pneumonia, when you are taking history, you have to ask whether patient is having upper respiratory infections, cough is there, or what is the duration of cough, what was the severity of cough, how it increased, what is the sputum production, whether it is large amount, blood tinged sputum. All these things clinically they are important, because lobar pneumonia come with severe cough, breathlessness, chills, rigors, and hemoptysis. Hemoptysis is a classical feature of most of the community acquired pneumonias like streptococci. But if you take viral infection, viral pneumonias like COVID or H1N1, they come with URTA symptoms 1 or 2 days, high degree fever. Third day onwards, they develop cough, breathlessness, high degree fever. Then you take X-ray, it will be bilateral pneumonia. Their symptoms in LRTA like symptoms will be very minimal. They have sudden onset of breathlessness, cough, and they go to pneumonia. Whereas in bacterial pneumonia like Streptococcus pneumonia, they can come with high degree fever, chills, rigors, hemoptysis, and when you auscultate, you can see only one side pneumonia, lobar pneumonia. That will be the classical finding. And if you see the saturation of the patient, viral pneumonia patients desaturate faster than bacterial pneumonia. Bacterial pneumonia, the advantage, it is actually disadvantage for the patient, but the advantage for the doctor is it's a lobar pneumonia and is confined to one lobe. Whereas viral pneumonia is an extensive pneumonia, bilaterally patient deteriorate very fast. But most of the H1N1 case or COVID pneumonia, they don't go to that pneumonia state. They just end up with upper respiratory infection or some sort of viral LRTA, then they stop it. Only very few number of patients will go to the complication. Whereas bacterial pneumonia is not like that. And Madam has told about atypical pneumonia. So we can classify bacterial pneumonia to typical and atypical. Typical will have classical finding, high degree fever, chills, rigors, hemoptysis, all these things. Whereas atypical will not present like that. They have minimal symptoms, mild fever, mild cough, mild breathlessness, progressive disorder, and they also can have other features like hemolysis. They can have like hyponatremia, symptoms of hyponatremia, all can be there. And very rarely, since we are in emergency room, we see patients with altered behavior in pneumonia. That can be due to hypoxemia, that can be due to toxic encephalopathy, that can be due to hyponatremia. So they also come into picture in emergency room, but routinely they come with cough, breathlessness, all these things, and we always have to ask the family history of the same illness. Family history means because most of the time it is due to virus. Viral fever spreads in family very fast. Okay, that also should be taken care.
Okay. And examination findings? Like
Examination finding, normally, see, if you know the pathology of pneumonia, you'll understand. There are few phases for pneumonia.
Right.
One is stage of congestion, stage of red hepatization, stage of gray hepatization, stage of resolution. Depending on the stages, you can get various findings.
Right.
For a stage of congestion, that is only blood congested in that area. You may not get any finding, or you may get very fine crackles. But whereas in red hepatization, gray hepatization, it's a consolidation of the lung. You get all typical findings of pneumonia, like you get bronchial breath sound, you can get reduced breath sounds, all these things. But suppose you get a consolidation with obstructed bronchus, you don't get anything. Okay, so that is a problem in pneumonia. You read lot of clinical findings in textbooks, but in actual patients, you may not get anything. But at the resolution phase, last phase of the pneumonia, definitely you get crepitations. That is a phase, the pneumonia which is consolidated is going to resolve, and you get a lot of fluids, you get a lot of pus in the lungs, and that produces coarse crackles. Some patients can develop pleural effusion, synpneumonic effusion. So you get percussion dullness, reduced breath sounds, all these things in that phase. Okay. But in a general clinical examination, somebody come with pneumonia. When you auscultate, very rarely you get all these typical findings given in textbooks. But classical findings in pneumonia is bronchial breath sound. That is a classical finding of consolidation.
Okay, right, sir. Can you also just quickly give an outline of the various investigations which we do? We do have domain experts from radiology and microbiology, but just a quick outline of what are how will you
So whenever
investigate?
you see a lung infection, whether it is LRTA, URTA, first investigation we always do is CBC and CRP. Complete blood count. We know that bacterial infection, complete blood count, there will be increased WBC count, whereas in viral infection can be low or normal. CRP will be always raised in all types of inflammation, including pneumonia. Okay, so these are the basic investigation we do. Then we do a chest X-ray. What we observe, most of the patients, initial phase X-ray may not show anything, but in a classical consolidation, you can see white homogeneous shadows, whereas in bronchopneumonia, it will be bilateral extensive inflammation. Okay, so these are the basic investigation. Then we do procalcitonin to know whether there is any bacterial infection, blood culture. These are the basic investigation do. Then other routine investigation like creatinine, urea, LFT, all these things we can do.
Okay. Dr. Shilpa? X-ray remains a major tool of investigation in workup of pneumonia. Can you just tell us what are the usual findings? Is there any findings specific to etiologies and things like that?
Yeah, so like you said, chest X-ray is the first line investigation if we want to do an imaging for the diagnosis of pneumonia. Right. Now, based on the radiological or morphological pattern that is seen on a radiograph, you can broadly divide them into lobar pneumonia, lobular or bronchopneumonia, and interstitial pneumonia. Right. Of that, between lobar and bronchopneumonia, definite etiological differentiation might not always be possible based on imaging pattern alone, but most lobar consolidations or lobar pneumonia have a bacterial origin, just broadly speaking, whereas interstitial pneumonia on the other end of the spectrum, where you have fine or reticular kind of shadowing on both lungs diffusely, are mostly seen associated with viral pneumonia, pneumonitis, like RSV or PCP kind of appearance. Now, what we see reflected on the radiograph is basically the consolidation, like sir said. What is consolidation? It is basically involvement of fluid, cellular infiltrates, exudates, everything within the alveolar spaces or the air spaces. So they get filled with these fluid material, and that is reflected as an opacity or a density on the chest radiographs. Okay. So this is at the airspace level. Okay. And when a whole lobe or a large segment of a lobe is involved, that is called lobar pneumonia. Okay. Mostly we see it with bacterial pneumonias like strep or Haemophilus, or sometimes in Staph aureus also. And then we go by a few signs on X-ray to say that this is consolidation or a pneumonic patch. One is this opacity. The other is air bronchogram, which is basically the airway that leads to that consolidated lung is not opacified, it is still patent. So you see that air-filled branching pattern within that opacified lung. That is called an air bronchogram. Of course, sometimes you can get fluid within that. You can have an obstructed bronchus, in which cases you would not find the air bronchogram. Right. The other thing we see is based on which part of the lung is involved. So which lobe. So like this is based on the anatomy or the organization or the structure of the lung. So which lobe, which segment is involved will determine what part of the X-ray is opacified. Right. So that is lobar pneumonia. Bronchopneumonia, on the other hand, usually has a multiple involvement or bilateral involvement, which may or may not be symmetric. Sometimes it might be asymmetric. So you generally have kind of a perihilar or a peribronchial patchy kind of infiltrate rather than the homogeneous opacification that you see on a lobar consolidation. So this is the very basic differentiation between lobar and bronchopneumonia. Okay. Lobar we can mostly consider to be bacterial, but to be honest, frank differentiation between the etiology might be impossible.
Okay. One of the other tools which we usually depend upon is the CT scan. So when is really CT indicated in a workup of pneumonia, and what are the extra information or extra findings one would get?
Yeah. So for most straightforward cases of pneumonia, as seen on clinical examination and a chest radiograph, you may not need to proceed with a further cross-sectional imaging like CT. CT is generally indicated when you have, like Madam said, you have hospital-acquired pneumonia. So you already have a patient in the hospital and then secondarily develops to pneumonia. Then you want to know what the cause of it might be. You might have to proceed with a CT. More than that, if you have a pneumonia that is not responding to your standard care of treatment, or the patient develops some complications related to that, to evaluate that further, CT can be a good tool. In immunocompromised patients, CT is usually a first line of investigation rather than a problem-solving tool, because it gives more information as to what might be the organism also, not just telling you which part of the lung is involved, but can give you clues as to what might be the organism. Another similar condition is when you have recurrent pneumonia. So if you have a patient coming back with recurrent pneumonia, either in the same part of the lung or in different parts of the lung, again here CT will be very useful, especially if it is pneumonia occurring in the same part of the lung, again and again same lobe is getting involved. Then you are suspecting, is there something underlying, is there a mass lesion, is there a structural malformation? For that evaluation, CT is a very good problem solving tool.
Okay. And the findings you told earlier, like the air bronchogram and everything, does it just appear on the CT also?
In CT also, it is similar findings. So if you have a lobar consolidation with air bronchogram, again you will see a dense area of opacification or non-aerated lung with or without air bronchogram, depending on the airway is patent or fluid filled. Similarly, bronchopneumonia, you will have bilateral, symmetric or asymmetric infiltrates, which will be more patchy rather than organized in appearance.
Dr. Divya, so what are the usual microbiological tests one should think about in a workup of pneumonia?
So when a patient is having pneumonia, is admitted, the first is the specimen. So depending upon whether it is the patient can give sputum or not, that is the most common specimen, non-invasive specimen that you can collect from a patient. Right. So sputum is usually sent for culture. Other than sputum, the lower respiratory tract infections, you can send BAL, protected specimen brushing, and if there is any ventilated or intubated patients, you can send ET aspirate also. So when you're sending the sample, the first thing we do is a microscopy. We do a gram stain. Right. So that will help you to know the quality of the sputum. So if you send an ideal sputum or a good quality sputum, will only give you a good result. Right. So to know the quality of the sputum, there is a grading system which is used called as the Bartlett's grading. Okay. So in which we see the inflammatory cells, the pus cells and the epithelial cells. If the squamous epithelial cells is more, then we consider it as not a good sputum. That is in the simple words. Right. So ideally we say that if the pus cells is more than 25 and the epithelial cells should be less than 10, we grade it and we get a Bartlett score of 0 or less. Then the 0 or less is considered as a contaminant or a saliva. Okay. So ideally it should be more of pus cells. So once you get a good quality sputum only, you should go for a culture. Otherwise, you have to reject the specimen and ask for a fresh sample. A mucopurulent part should be taken for gram stain as well as culture, so that you get a good result. But in case of typical pneumonia. But if it is an atypical pneumonia, the gram stain itself will not give a result. We will not be seeing any organism, but inflammatory cells will be there, and the culture will not grow. Like mycoplasma, it requires special transport medium, and it will not grow into routine culture. It requires specialized medium. Right. In such cases also, you have to go for other tests like serological tests. So serological test, ELISA, immunofluorescence, all those should be should be done in case of an atypical pneumonia. Right. So other than that, you can also go for ICTs. In case of bacterial pneumonia, you have urine streptococcal ICT is there, lateral flow assay is there, and Legionella ICT is also, Legionella pneumophila ICT is also there. If it is a viral infection, if you are suspecting influenza, then also you can go for a CAR test. Influenza CAR test is also there. Other than the serological test, you can also have PCRs. Now we have a BioFire syndromic testing panel where it has both pneumonia panel as well as respiratory panel. The respiratory panel will give the atypical pathogens as well as the viruses. They target 23 pathogens, and there is a pneumonia panel which targets bacteria as well as viruses and some resistant genes also. So these
are PCR based, or
it's a syndromic multiplex PCR. Okay. So these will help. Also, there are other PCRs, conventional PCRs. So this can give you an idea on what pathogen and helps in targeted treatment of the pathogen.
Okay. From the sample point of view, do you go for bronchoscopic assisted lavages and things like that if it is not?
If it is, ideally, most of the samples will be sputum. Okay. So if you're going for a bronchoscopic lavage, you can send BAL also.
Okay. Right. To Dr. Nanda. So, during your initial comments, you did mention about the mild anatomical difference between the left lung and the right lung. How does it influence the development of pneumonia?
Yes, sir. So the general differences are one that I've already mentioned, lobes, difference in the lobe. Right has 3, left is 2. Right. And the right lung is larger and wider when compared to the left. And the anterior border of the right lung, it is sharp and it is straight. While the left, even though it is sharp, it is not continuous like the right, because it is interrupted by the cardiac notch, which is because of the presence of the left ventricle, followed by a lingula. It is a tongue-like projection. Okay. So actually lingula is thought to represent the middle lobe of the left lung. Right. The anatomical structural difference that could lead to pneumonia is the right bronchus. Okay. So the right bronchus is wider and is vertical and lies in line with the trachea. Okay. So there is more chance for inhaled pathogens or foreign bodies to get aspirated into the right lung. Okay. And one more thing is the middle lobar bronchus, the middle lobar bronchus of the right lung. Okay. So this bronchus is actually surrounded by the hilar lymph nodes. And so the lymphatics from the lower lobe and the middle lobe is draining into this hilar lymph nodes. Okay. So whenever there is a malignancy or an infection, when this lymph node gets enlarged, this middle lobar bronchus, the diameter is narrow when compared to other lobar bronchus. Okay. So what will happen, the hilar lymph node, they'll get enlarged and they'll compress this middle lobar bronchus. Okay. So that can lead to collapse, and it is called as middle lobe syndrome. Right. So these are the anatomical differences.
And with regards to alveoli and bronchioles, how does it influence the spread of pneumonia?
So alveoli, these are basically pockets filled with air. Right. So they are lined by 2 types of cells. Type 1 cell, which are basically squamous cell, and they contribute to 90% of the alveolar surface. And these cells, the basement membrane of these cells fuse with the basement membrane of the capillary endothelium, and that forms the air-blood barrier, and that is where the diffusion of the gases takes place. And then we have a type 2 cell, the type 2 pneumocyte, that produce surfactant, so that help in reducing the surface tension and thereby prevent the alveoli from collapsing. Okay. So separating 2 alveoli, we have an interalveolar septum, which basically consists of elastic fibers that help in expansion of alveoli, some reticular fibers to provide support, and the most important, the capillary endothelium. Now inside this alveolar lumen, we have something called as the alveolar macrophages. They are either residents or they are recruited from the systemic circulation. Okay. So they have the ability to phagocytose all the dust particles, pathogens, and they are responsible for the innate immunity inside the alveoli.
Okay.
So whenever there is an infection, this membrane is broken first,
Right.
and then this epithelial cells, that is the squamous epithelial cells, are bound to each other by tight junctions. So that can be broken, and then the alveolar macrophages, their functionality will be damaged. So that can lead to spread of infection.
Okay. Girish sir. So there are various scores which are said to be useful in assessing the severity of pneumonia. Can you just name something which is
There are
very
two
useful?
important scores in emergency room or in routine practice.
Right.
One is pneumonia severity index.
Right.
There's a big scoring. It is very difficult to remember. There are a lot of apps which can tell you what is the severity of pneumonia.
Okay.
So depending on the severity, you may admit the patient in, you may discharge the patient, you may
Okay.
admit the patient in a ward, you may admit in ICU, HDU, all these things.
Right.
But other score is very simple. You can remember CURB 65 score.
Okay, sir.
In that CURB 65, C stands for confusion. You all may be knowing that depending on the GCS, we try to intubate the patient or not intubate, we admit the patient in ward or like monitoring purpose.
Right.
Confusion is very important. But what are the reasons for confusion? I already told. It can be because of the toxic encephalopathy, it can be due to hyponatremia, it can be due to hypoxemia, various reasons are there. But confusion tells you that patient is bad. Next one is urea. You may be knowing that whenever you have severe dehydration or hypoperfusion, urea level will be disproportionately elevating than creatinine.
Okay.
Or if the pneumonia involves multi-organ dysfunction syndrome and urea creatinine both can be elevated. So that is another parameter. Third one is respiratory rate. R stands for respiratory rate. If the rate is more than 30, that is a severity index or it's a parameter.
Right.
Then next one is blood pressure. You may be knowing that whenever you are infected or you go for sepsis, your BP is always low. If the BP is persistently low in spite of fluids or drugs like noradrenaline, then there is another parameter. Last one is age more than 65.
Right.
The advantage of this scoring is you can predict the risk of death. Okay, so you may be knowing that when you talk to the bystander after seeing the patient, we have to predict
Prognosticate,
what is his severity. Sometimes patient may be very bad and you can even predict the death. According to this scoring, I just read out the scoring. Score 0 to 0.7, risk of death is 0.7%. Score 1 is 3.2%. Score 2 is 13%. Score 3 is 17%. Score 4 is 41%. Score 5 is 57%. So that tells you that what is the predictability of this scoring. Okay.
Right.
But that doesn't mean that all patients with confusion, sometimes the confusion can be hypoglycemia in pneumonia. So if you correct the hypoglycemia, patient will become all right. Okay. So the scoring is always you have to correlate with the clinical scenario and scoring system. So that will give some we can predict the mortality, morbidity in this type of patients in pneumonia, especially in a situation like emergency medicine or acute medicine in ICU. We can predict. There is an advantage of this scoring, but you cannot go always with the scoring and predict death like that. Okay, sometimes this scoring system can go wrong also.
Right. So also now, can we have a quick word about the first line of management in pneumonia? What are the initial management strategies?
So, like previously I told that we have to basically divide this pneumonia into two major categories. One is viral pneumonia, other one is bacterial pneumonia.
Right.
Viral pneumonia in our country, the most common cause is H1N1. Okay. So patient can have URTA symptoms with pneumonia. You can start oseltamivir 75 milligram BD. Right. COVID, you may be knowing that there is no major treatment. There are a lot of drugs which are given in the guidelines, but nothing is going to work really. So, in viral pneumonia, generally we start with oseltamivir 75 milligram BD, and some doctors try azithromycin. Right. That drug has got some anti-inflammatory action in the lungs, so that can be tried in most of the patients who is having viral pneumonia. But if you take bacterial pneumonia, you can again classify these bacterial pneumonias into community acquired pneumonia and hospital acquired pneumonia. If you read standard textbooks in community acquired pneumonia, first line drug of choice is broad spectrum respiratory quinolones, that is levofloxacin or moxifloxacin. These are the two drugs which are given in all standard textbooks. Right. But in our country, the problem is tuberculosis. These drugs come under second line category of anti-tubercular drugs. So we try to avoid these drugs in most of the pneumonias. We go for some other drug, but if you read all standard textbooks, like including Harrison, Davidson, everywhere it is given that these are the first line drugs. But we try to avoid that. Instead of that, we can go for amoxicillin clavulanic acid. That's a very good drug which covers almost every organism. The advantage of moxifloxacin, levofloxacin is, if you know the spectrum of these antibiotics, you'll understand. They cover normal community-acquired pneumonia organism like Streptococcus, Staphylococcus, gram-positive cocci, everything will be covered. They also cover most of the gram-negative infections. They cover atypical pneumonias. They cover anaerobes. Right. So we are covering all these organisms by simply giving this levofloxacin or moxifloxacin. Right. But the problem is they are second-line anti-tubercular drugs. So we try to avoid it. Okay. But if you take amoxicillin clavulanic acid, that is a drug which can cover gram-positive infection. Right. So it is a very good choice in community-acquired pneumonia, but they are not a good choice in hospital-acquired pneumonia. So depending on the scenarios, you have to select one more drug. Okay. Like if you are suspecting a gram-negative, suspicion is there. Suppose like in COPD with secondary infection, you always suspect a gram-positive flora with a gram-negative, add on some bacteria. So you can give amoxicillin clavulanic acid, but you have to definitely add a gram-negative coverage. So you can give ceftriaxone, you can give some other third-generation cephalosporins, or you can go for piperacillin tazobactam. That all depends on your scoring system I have explained previously. Right. Depending on the severity, you can go for that. Right. Then there is definitely a change between a normal lung to an abnormal lung. Disease. So normal lung, most of the bacteria are gram-positive cocci, but abnormal lungs, you get additional gram-negative flora also in that. So they also can produce infection. Right. So you have to think of all these things. But the most advised treatment in pneumonia is moxifloxacin, levofloxacin. We are avoiding only because of the fear of anti-tubercular resistance. Okay. You can go for a gram-positive. Basically, you cover with gram-positive antibiotic, add gram-negative. But a hospital-acquired pneumonia, you go for Madam has told, pseudomonas infections can be there. So you have to go for an anti-pseudomonal drug. So we normally prefer piperacillin tazobactam in that type of situations. Okay. But depending on severity, you can go to any extent. You can go to you can cover fungus, all other things also can be covered. But always keep in mind that in our country, tuberculosis is one of the cause for pneumonia, or in a patient who is having tuberculosis, that patient can develop an add-on pneumonia in that lung.
Okay. To Dr. Shilpa. Something which has gained a lot of interest is the CORAD score post the COVID. So what exactly is this CORAD score and what's the relevance?
Yeah, so CORAD scoring is basically a systematic reporting system that is used in situations where there is high prevalence of COVID. Okay. Whereby we look at the imaging pattern on CT and score it to try and tell what is the likelihood of this infection being a COVID. Okay. So we look at the imaging pattern on CT. So the CORADS is basically 1 to 6. Okay. Where CORADS 1, if you say CORADS 1, it means there are changes on the CT scan, but they do not look like COVID. Okay. In fact, they look like either it is normal or it is some non-infectious pathology. Right. So the imaging findings are suggestive of a non-infectious pathology or it is normal. CORADS 2 is where you have changes where the imaging findings are typical for some particular infection. You can tell by the imaging itself, like either it is a bronchiolitis, but there is nothing to do with COVID. So you can say with surety that it is not consistent with COVID. So the chance of it being COVID is very, very low. CORADS 3 is indeterminate. So you have findings on the CT scan which could go either way. There are some findings which may be suggestive of COVID, but it is not typical of COVID. So it is indeterminate. There is some infection, it could be some viral infection, but there isn't enough in there to tell you for sure that this is COVID. Then you have high index of suspicion, that is CORADS 4, where most of the abnormalities you see are fairly suspicious for COVID. And then you have CORADS 5 where it is very high. So high and very high is a little bit of a grey zone, but very high means most of the findings that you see on COVID or that has been described in COVID are seen in your patient. So the chances that this is going to be COVID is very high. So that is CORADS 5. CORADS 6 is where you have these imaging findings plus you already have a positive PCR.
Okay.
So that is correct. That is confirmatory. So you have both imaging findings and a positive PCR.
Okay.
You call it CORAD 6. So these are the 1 to 6 CORAD scoring that you use to differentiate, to give the risk of COVID.
Okay. Done that. So, one structure we probably haven't discussed so far is the pleura. Like again, it comes into picture while we deal with the complications of pneumonia and things like that. What are the important things regarding the pleura which one should be knowing?
So pleura is actually a membrane that covers the lung and also the surrounding structure. So it has two parts, a parietal pleura and a visceral pleura. So parietal pleura, it covers the rib cage, so that is called as costal pleura, the diaphragm, the diaphragmatic pleura, lateral aspect of the mediastinal pleura, and the apex of the lung, that is the cervical pleura. So this pleura is sensitive to pain because it is innervated by intercostal nerves and the phrenic nerve. The visceral pleura covers the lung and it is very closely adherent to the lung. It dips into the fissures, so that is what gives the lung the shiny appearance. So this pleura is insensitive to pain because it is supplied by pulmonary plexus. So between the visceral and the parietal pleura there is a pleural cavity which contains the pleural fluid. So it is a thin serous fluid. Now this fluid acts as a lubricant and it prevents the rubbing of the two pleura against each other. So in pleuritis, where there is inflammation of the pleura, inflammatory exudates appear on the surface. So they move against each other and there is friction. So patient will present with pain. He'll have pain. And in pleural effusion, when there is increased production or accumulation of fluid in the pleural cavity, the subatmospheric pressure decreases. So what will happen, this pleural effusion, the lung, it will retract towards the hilum and it will push the mediastinum and the heart to the opposite side. So that is what happens in pleural effusion.
To Girish sir. So including pleural effusion and pleuritis, what are the usual complications one should be looking for, and what is the specific management strategies for managing the complications of pneumonia?
So if you are seeing this patient in emergency room, we always think that whether this patient go to ventilator or not. That is the first thing we always think. So that is the most important complication of any pneumonia. Hypoxemia, hypoxic encephalopathy. This patient may require mechanical ventilation, and sometimes what happens is after putting the patient on mechanical ventilation, they even can develop hospital-acquired secondary infection. Okay, so that is one important complication of pneumonia. You see a normal physician's point of view, pneumonias normally can develop pleural effusion. In that, again, patient can develop pus in that, and empyema is another possibility. You may have to put a chest tube, drain, and you have to relieve the symptoms of that empyema. Sometimes what happens is patient can develop toxic encephalopathy. Toxic encephalopathy is anyway these pneumonias will produce toxins. Sometimes that toxin production will be dysregulated and it can affect your brain. Toxic encephalopathy is another important thing. Sometimes you can develop multi-organ dysfunction syndrome. Other organs also can be involved. In that case, we always take blood culture in pneumonia. But in a normal pneumonia, we see only 30% of the patient's blood culture will be positive. Whereas in multi-organ dysfunction syndrome, you can see large number of patients can develop blood culture positivity. Again, I have told previously procalcitonin. There is another important tool. What is the extent of systemic infection produced by this pneumonia? So what we routinely see in lung infection, we can see procalcitonin 40 or 50, 60. But when they develop multi-organ dysfunction, sepsis, it will be more than 100 or 150. So that also we should keep in mind. This is a common complication we see in acute phases. But afterwards, many patients can develop complications like they can have cavities, they can have infection in the cavities, fungal infections in the cavities. These are the long-term complications. Some patients can develop bronchiectasis after some time. So common problems. In ventilated patients, you can see there will be obstruction of the major bronchus. Okay, that you might have seen. Suddenly, patient one side lung is completely collapsed in a patient who is having pneumonia. That is because of the mucus plug obstruction in the major bronchus. So these are the common things we see in our practice. But there are a lot of other complications which we cannot anticipate. Because pneumonia affects not only the lung, it also affects your full body. Hypoxemia is a major problem. You can get lactic acidosis, you can get hypoperfusion to various tissues, hypoxemia to tissues. So many other complications can happen.
Okay. To Dr. Shilpa. So again, is there any role of ultrasound in diagnosis and management of pneumonia, and what are the usual limitations of this technology?
Yeah, so ultrasound is actually a very good tool both in diagnosis of pneumonia as well as follow-up.
Yeah.
So, but mostly used as a problem-solving tool when you have an X-ray and you have some questions remaining as to is it really still pneumonia, or you have a high clinical suspicion of pneumonia, but the X-ray is not really corroborative for that, or so that happens when you have consolidations in blind areas, like your X-ray might be not showing the pneumonic patch well, especially the retrocardiac regions. That is one blind area that is often missed. The ultrasound has a very good pickup for that. So if you are suspecting a lower lobe retrocardiac pneumonia, specifically if you look in that region, so again the same thing what you are going to see is the consolidation. So that non-aerated lung with the air bronchogram you will be seeing on ultrasound. So that corresponds very well with the pathology of the disease as well. So like sir said, that gray hepatization, red hepatization stage is where the consolidation is happening. That is exactly what we will see on ultrasound. So you'll see that hepatized looking lung, that lung that looks like a liver. You will see that consolidation on. So ultrasound is a good tool for diagnosis. More than that, and that is probably its most common use, is to look for complications, especially pneumonic effusions and empyema. So if you have an associated fluid, to look for the fluid, to quantify the fluid, to look at the character of the fluid. Is it just simple fluid, or is it echogenic and thick and loculated? Does it need to be drained? Even if you drain, do you think it is going to come out on its own, or is it so thick that it might need to be, you might need to add some lytic agents to it, or do you need an ICD or a pigtail, or do you need to go for surgery? And then after that, it helps in the guidance of the same said procedure. So if you want to aspirate the fluid or put in a drain, ultrasound is a guidance tool to locate and reach up to the fluid. So ultrasound in that way is a very good tool. Even for follow-up of this fluid loculations also, it can be used well.
Okay. Divya, the last question. We often hear about certain vaccines which has its role in prevention of pneumonia. Can you just elaborate on who are the candidates who will benefit from vaccine, and what are the vaccines usually available?
Vaccines play a very important role in pneumonia.
Right.
It helps in the target specific pathogens. So first, talking about the bacterial targets, the most important is the pneumococcal vaccines. So the pneumococcal vaccines, there are two pneumococcal vaccines, the PCV13 and the PPSV23. One is a protein conjugate vaccine, and the other is a polysaccharide capsular vaccine.
Right.
So the PCV13, that is earlier, now it is PCV15 and 20 has also come up, and it is PCV is usually given for children's because they don't respond to the polysaccharide vaccine. So PCV conjugate vaccine is more important in children.
Right.
Other than children, in elderly, more than 60 years, splenectomized patient, explenic patient, and also immunocompetent patients with CSF leak or cochlear implants, all these are candidates for a pneumococcal vaccine.
Okay.
Then coming to Haemophilus influenzae, that is a common organism that is seen, and that is included in the National Immunization Schedule for children, and it is given along with DPT as a pentavalent vaccine at 6, 10 and 14 weeks of immunization. So coming to the viral vaccine, the most important is the influenza vaccine. Earlier in the southern hemisphere, we were using a trivalent vaccine, but currently in the 2024, the current recommendation is a quadrivalent vaccine. The quadrivalent vaccine should be included with the Yamagata lineage should also come into the southern hemisphere. That is the current recommendation. And then you have the COVID vaccine, the Covaxin and the Covishield. And influenza vaccine, it should be given as annual, seasonal. It's a seasonal vaccine. Annually it should be given. It can be given to all ages. Flu shot should be given. COVID also, Covaxin and Covishield is there. Now we are out of the pandemic, so now it is not recommended. Already immunized patient, if they are immunocompromised, they can take additional booster doses. And now a new for RSV, there is a new vaccine coming up, that is a recombinant RSV vaccine, which target the pre-F subunit, which is ideally given for elderly more than 60 years, and infants are the target, and also given for pregnancy with 32 to 36 weeks, so that the up to 6 months of age the children will be they get the immunity. So these are the common vaccines that we use which is important in pneumonia.
Okay. So with that, we have come to the end of the pre-prepared questions. The last round of questions to start with. Can you just tell what are the important questions a student should expect from this topic, and also if we have missed any other relevant things in this, you can elaborate on that.
Some questions would be difference between the right and left lung, bronchopulmonary segment, structure of alveolus, and short note on pleura.
Okay, so we have covered it.
Yeah.
Right. Okay.
So from microbiology, they should know about the classification and the etiological agents.
Right.
They should be knowing the laboratory diagnosis of community acquired, hospital acquired, especially in one point that we didn't go in deep is the ventilator associated pneumonia. They should be knowing how we are diagnosing the ventilator associated pneumonia also they should look into. Otherwise, the microbiological diagnosis of lower respiratory tract infection or pneumonia is important. And the role of vaccines is that's.
So as far as radiology is concerned, appearance of pneumonia, different patterns of pneumonia on chest radiograph. So for that, knowing the radiological anatomy of the lungs is also important. So just like the gross anatomy, radiological anatomy and how different lobes where it is seen, that is also important. The role of both CT and ultrasound in the diagnosis and management of pneumonia, trying to differentiate between the different etiological factors of pneumonia, and CORADs also, especially with the recent pandemic. That is also one topic.
So,
MBBS students should know about community acquired pneumonia, and that is the main question in medicine for them. Then they can ask atypical pneumonias. Community acquired pneumonia is the main question. Atypical pneumonia is normally asked as a short note. Then H1N1 and COVID. These two questions also can be asked for MBBS students, and they all should download CBME curriculum and see what are the core group of questions in these topics, because we teach a lot of things for MBBS students. Some topics are not like they are coming not under core curriculum. So questions should be asked only from core curriculum, whatever topic you are teaching. So they should download core curriculum competencies from CBME site, and they should read about questions in all these topics, so they'll get a better understanding about the questions.
and from a practical aspect, like case.
Practical aspects, normally you may be knowing that pneumonia patients are very sick.
Right.
We don't keep pneumonia patients for MBBS students as an exam case, but you can ask chest X-ray, like madam told, they can keep a chest X-ray of pneumonia and they can ask what is a finding in that. And sometimes very rarely you can get pneumonia in resolving stage. That can be kept as exam case. Otherwise, routinely pneumonias are not kept as exam case because they are very sick. Patients are very sick.
Okay. Thank you all.